are. Good evening, ladies and gentlemen. Welcome back to another edition of the Ultimate Pulmonary Wellness Webinar Series. Tonight we have a super giant of pulmonary medicine, pulmonary care, pulmonary exercise, cancer care. Donna Wilson, welcome to the show, Donna.
Thank you.
Donna has hundreds of fans who've signed on tonight, and this is our biggest webinar, our biggest draw, Donna Wilson. So before we start, I want to thank you. I want to thank the American Lung Association and the Better Breathers Club. I want to welcome all of you, and I want to shout out to the Ultimate Pulmonary Wellness Facebook group. Again, Ultimate Pulmonary Wellness Facebook group. And we are honored to have Donna here. Let me tell you a little bit about Donna. So Donna and I first started circling paths probably about 23 years ago when I was 5. And basically we've known about each other for all this time, and I've always had tremendous respect. Back in New York City, you know, at that time, people were not doing much with respect to exercise. It was basically you'd have surgery and then you're thrown back into the river. Maybe you're gonna, get going again or not. And over and over and over again, I'd hear about this woman, Donna Wilson, and I'd hear about Donna's group, and I was like, I have to figure out who she is, what is she doing, and here we are 20-something years later. Now, let me tell you about Donna. So Donna Wilson is a clinical nurse specialist, a personal trainer, and she works at the Integrative Medicine Service at Memorial Sloan Kettering Cancer Center, where she has been since September 2000. She has earned a diploma in nursing, a diploma in respiratory therapy, a bachelor's in biology, a master's in nursing from the esteemed Mass General Hospital Institute of Health Professionals, and she is a cardiopulmonary nurse specialist. She is a certified personal trainer by the Aerobics and Fitness Association of America. So one thing I love is when people have multiple disciplines. So count them up. Donna is a nurse. She's a respiratory therapist. She's an exercise specialist and personal trainer. So she's the person you want to know and ask questions about this stuff. Her professional experience includes working at Mass General Hospital for 17 years as a clinical nurse specialist in the ICU and coordinator of the Respiratory Care Consultation Service and Lung Transplant Program. In 1992, she came to New York City and joined the nursing staff at Memorial Sloan Kettering Cancer Center as a pulmonary and thoracic clinical nurse specialist. She has a breathing lung exercise video on YouTube. She has multiple exercise videos on YouTube, so search Donna Wilson. She currently sets up exercise programs for all types of patients going through cancer treatments, including chair aerobics, strong bones, back and shape aerobics class, PEX class for men. What is PEX? Prostate, okay, gotcha. Prostate exercise and personal training. Her focus is to rebuild strength, restore flexibility, achieve better balance, and decrease fatigue and breathlessness in all patients. Sound familiar, people? She believes in collaboration with all services to give quality care to each patient. So this lady is not competitive. She's not political. She's going to do what's best for the patient. In 2012, she produced a DVD called, appropriately, The Wilson Technique for Women After Breast Cancer Surgery and Who Are Living with Breast Cancer. In January 2009, she organized the first breast cancer survivor, listen to this, Dragon Boat Team, okay? If you don't know what that is, look it up, okay, because it's fascinating, in order to promote dragon boat racing as part of a healthy lifestyle and an innovative and unique support system for survivors, and as a mechanism to raise funds for cancer research and survivorship programs. She has dozens of scientific publications, hundreds of teaching and speaking engagements on every topic possible. She has many exercise videos on YouTube and an exercise DVD, as I mentioned, the Wilson Technique workout specifically for breast cancer survivors. And if you didn't notice, and the reason why I'm wearing sleeves tonight, she has guns like Arnold Schwarzenegger. So Donna, welcome to the show, and believe me, I gave you the short version. Welcome, and thank you so much for being here.
It's a pleasure. It's absolutely a pleasure.
All right, so I want to talk, we have a lot to talk about tonight. We're going to have a lot of questions from the audience. There are a few things from your past. Don't worry, no sordid details, but I want to know about, I'd love to know more about when you were working on the chest physical therapy service at Mass General.
Well, let me put it this way. I went to Mass General in 1974, and prior to that worked with mostly heart patients. And so I walked in the door and said, I want to work in the open heart unit. They said, well, we don't have any room there. So I went to the respiratory intensive care unit. And that's where my life started as being a lung nurse. And I found it fascinating at that particular ICU. We worked with all kinds of patients. Anything could happen to them if they had acute respiratory distress syndrome. So we had patients that had neuromuscular disease, patients that had chronic lung disease, surgical patients, trauma patients, all type. And that's where I got really interested in working with lung patients. And then, many years of working in the ICU, nights, evenings, all that kind of thing, the chest physical therapy department said to me, they needed people. So I went and worked with them, which was a couple of years of learning almost everything you can imagine about lung. I mean, chest physical therapy, working with your hands on someone's chest wall is really where you understood what was going on. You understand what kind of chest expansion they have. You can probably feel how you can change phlegm in their lung. So it was very exciting, and I worked with all groups. I didn't work just with one group. I was in the neonatal ICU to, the adults, to the children, and a lot of cystic fibrosis. So it was actually a very wonderful part that I can look back at and say, still to this day, physicians are sending me people to teach patients about pulmonary and bronchial drainage and chest PT because it's a need.
So what did chest PT that was weird. What did chest PT consist of at that time?
Oh, chest PT consisted of going in and evaluating if anybody had a lung infection or had atelectasis, what we call infection in the lung, or had mucus collection. We would go around and we would listen to their lungs and evaluate them and put them in the proper lung position and do deep breathing, do vibration, percussion, and coughing. And coughing from every perspective, whether it's huffing or it's coughing or clearing your throat, anything we needed to do.
What's so interesting is that people don't understand the importance of being in the right position.
Oh, yeah.
And, we always talk about it like a ketchup bottle, which is that, if the ketchup bottle's upright, you can shake it till the cows come home and you're not going to get that ketchup out.
Yes.
And it's the same thing with mucus.
Yeah. Well, if you really, when you look at the lung, you know that the right lung has 3 lobes and the left 2, but there's 18 segments in the lung. And I can honestly tell you those years that I worked with the cystic fibrosis children is that you could just turn them one way, boom, and you could help clear them out. So it's very important. When I worked with lung patients or other sick patients at Mass General is that I did a lot of bronchial drainage, a lot of reverse Trendelenburg, a lot. Put them in a nice comfy position, get them all cozied up, get their head down, leave them there for a half hour. Come back, sit them up, have them cough, and boom, they were much better. It is, without a doubt, the right thing to do. I've had a pet peeve over the years. Obviously, I probably have quite a few.
Spill it. Confession time.
When I see someone working with someone that I know has phlegm in the base of their lung, and they're sitting up, as you said,
of course,
sitting up trying to get the cough and clear their secretions, it doesn't work. So yeah, it's body position. One of the things that, and I've been very active about saying, is the lung is a gravity dependent organ.
Absolutely.
It is tissue. So what you do with the chest wall and how you breathe is the muscles of your chest wall. So it's very important to keep the muscles of the chest wall strong.
Were you using any type of devices to help you at that time? Was it all manual?
All manual.
Okay, and what was the first thing that came in, like the Inspiron or incentive spirometry?
I think probably the incentive spirometer came.
And when you do chest therapy today, are you incorporating aerobic? You don't?
I don't,
okay.
No. Because I have to tell you that I think that the flutter valve and, the few of them, some of them work better than others. It depends on the way people use them.
For sure.
But I am very comfortable with still using my hands and really feeling that I can vibrate them.
Interesting. Okay, I would love to have you talk to Marion sometime, because we love the acapella. We love the aerobica because they're not as gravity dependent. They're not as position dependent as like the flutter. Like the flutter was a great idea, and we wouldn't be doing what we're doing without the flutter initially. But these tend to work quite a bit. Tell us a little bit about your time as the lung transplant coordinator, because that's something that everybody's fascinated with. What is involved in,
It's huge. When it came up, it was in probably the late 80s, 89 or so. One of the thoracic surgeons wanted to do lung transplants. So he and I developed the whole program. And basically the whole program was anyone, let's see, the number of patients we had, some had pulmonary fibrosis, somebody had pulmonary hypertension, we had a few with chronic lung disease. That was basically the wide range, I think, that we had. And they would come in and we would evaluate them for a transplant. If they looked like they would be a transplant patient, then I would be working with them. I also worked prior to that in Canada with some of the thoracic surgeons had done lung transplants first. Mm-hmm. And one of the things I learned very quickly with them is that I had them all exercise. Now, most of them were on oxygen. And so they would come in and in the chest physical therapy department, we had a couple of treadmills way back then, and we would make them exercise. So I made all the pre-transplant patients exercise. Now, what really happened was the ones that really exercised, we would get that when the lung came in and they had their lung transplant, if they had exercised, I got them off the mechanical ventilator within 24 hours.
Wow.
If they didn't exercise, it would take me a week, and that's a very high risk then of infection when you get a new lung.
For sure. Do you think, so you obviously believe in pre-op exercise. What about after exercise, after the transplant? How soon do you want people up and moving?
I think, within 24 hours you can get them up. If you don't, there's no reason why you can't get up. I mean, we operated on the chest, we get them on a walker, hook up their chest tube the way we give them some oxygen and get them moving. So first maybe the first day or so we'd go bed to chair, but then within the 2 or 3 days post-operatively they were up walking.
You're walking. Yeah. Okay. And what about how much oxygen do people get? Is there a limit?
You're looking at a time when it's interesting because, the oximeters weren't as popular.
Okay.
They were just coming out, so we would, rush to always have one. But, I really felt that if I wanted to maintain somebody walking, I wanted to maintain them with an oxygenation of somewhere about 92, 94%.
Perfect.
I just don't want them really low because that's going to cause oxygenation problems with the rest of the body. So I want to push them.
What would you say to the people who are going to say, okay, you don't want to over-oxygenate your patient, and this is the whole hypoxic drive myth, or doctors that tell their patients, oh, you can go down to 88 or 86, and as long as you come back quickly into the 90s when you stop?
I think it's really very much every person, because the thing is, if you have to make sure that they don't have heart disease. Mm-hmm. If they have heart disease and you're going down to 88, 86, that's a big issue.
Yeah.
So I think you have to look at the whole holistic situation and the whole person first when you make that decision. I do look at recovery time a lot. And even still to this day, I will do, a step test on someone, and I do a 3-minute step if they can do it, or whatever they can do, and then see how long it takes them to recover. If it takes them a really long time to recover, then I'm going to go back and say, what does that last EKG show? Or what the problem is. I have picked up some actually very interesting cardiac issues because they didn't recover very quickly. So I think that you have to look at the whole thing and understand the whole system of the cardiovascular system. You can't just look at a number and say, well, you're okay at 88.
Right. So we talked about this a little bit before, but just to be clear, when you say a step test, you're talking about stepping up a step and down a step. You're not talking about...
I actually use the YMC step test.
Okay.
It's a cardiovascular test. I have modified it to some extent with, if I have someone that's pretty healthy and I want to check them out, it's a 12-inch step, so it's high.
Okay. If
I have just the average person, if I have right now in this day and age, when I have a lung patient coming in with me, I tend to just use a 6-inch step. And I want to see how many steps they can go up and down. Hopefully, and I do it with a metronome. I don't want them to go as fast as they can.
Right.
I want to do 24 steps a minute, and I want to see what they are at the end of 3 full minutes, and then I want to see what their recovery is at the end of a minute.
And what do you do with people who right now are at home saying, oh my God, 24 steps per minute, I can't even do 2 or 3 steps?
Right. Well, the key is it's how you do the step. The average person doesn't know how. I mean, I'm not being, I'm just being honest, is that, most people don't know how to breathe when they go up steps. This comes to you of the power of your breath. What is the power of your breath? The power of your breath is breathing out. You will always breathe in. The change in atmosphere pressure, the change in lung pressure, you'll always breathe in. But people don't have good exhalation, or breathing out efforts. So when you look at steps and you literally go breathe out with each step that you go up, the time you get up a certain amount of steps, you're not going to feel that short of breath. What gives out on many of the patients when we're doing 24 steps, they can go the first minute, I find. If they breathe out, up, up, down, down, they're breathing out with each step. And then when they go to that second minute, their legs are getting tired.
Right.
Now, if you're not very efficient with your exercise performance, more blood flow is going to those muscles because the muscles are getting tired. So that's going to take away from the lung as well. So the thing is, then I look at that, and then if I stop them, then what my goal is then is to stop them at 2 minutes, not to push them to the point of exhaustion, but then put them on an exercise program and then bring them back in 3 or 4 weeks and repeat that to show from a biofeedback standpoint, look at the change you made.
Because you've learned these different techniques, you've gotten more comfortable with exercise.
And you've learned to build some strengthening.
Gotcha. So you were doing most of these things as a nurse. Why did you go and become a respiratory therapist and a personal trainer?
Well, it didn't go that way, actually. What happened was, as I nurse, then I wanted to go back and get my baccalaureate degree in nursing. Instead, I got my baccalaureate degree in biology because I thought it would broaden my horizon more. From there, I became a respiratory therapist because I worked in the respiratory ICU, and I could see the combination of being respiratory therapy and understanding all the technology of the machines, and being a nurse and understanding all of the pathology and working as a nurse and understanding everything. And then after that, I became and got my master's. But I didn't become a personal trainer until I came to Memorial Sloan Kettering. I was working within the hospital setting, mostly with ICU and thoracic patients, and I could see the need that people needed to exercise. And I also, now I'm in a community of just really one type of disease. I'm seeing all patients needed to move. All patients needed to exercise. And so I decided the best route to go is to become a personal trainer. And it's really been an asset because then I've put all of these things together and I can pull from each and understand so many aspects of what's going on with a patient.
So if we could just talk about some of the different conditions, if you could maybe tell us a little bit about what you feel are the most important, like what's the single piece of advice you would give to somebody with COPD with respect to exercise? Probably with chronic lung disease, and that's looking at that big umbrella, whether it's restrictive or obstructive or whatever, it is to lengthen your expiratory time. So is to really get the air out. One is to build sort of some strengthening of your chest wall, really strengthening your diaphragm, which is responsible for a good 60-70% of your effort of breathing in. Doing those kind of breathing exercises, and then incorporating exercise with your breath. So exercise, you have to learn how to breathe with each activity. So what I would do is you'd say, okay, if you think about it in a very easy term, if you push something, if you pull something, if you lift something, or if you bend over, you breathe out. So, and it's always amazing, so that if you're here and if I take my hands like this and do a fisted hand and I want to do a shoulder press, you have to breathe out to do it. If I find people when I'm with them and they pick up little 1-pound weights or something and they're like this, obviously the weight's not doing anything. So then I would increase the weight so they would have to use the breath properly. You have, no matter what you do with COPD, you have to learn with the lung function that you have is to breathe correctly. And you're always going to do exhaling on the exertion portion?
Correct.
Okay,
Always.
Gotcha. Is there a difference in what you would tell a pulmonary fibrosis patient or a restrictive lung disease patient?
Well, the difference there would be is that the pulmonary fibrosis or restrictive lung disease, they're going to just have a shallower, more frequent breath. but it's still, I'm going to try to lengthen. I'm working with someone now who has very severe restricted lung disease from all the radiation she got from her Hodgkin's disease. So I have to really work on her, really working hard, because she would like to just go and then take another breath in. Whereas I want to really make her lengthen and coordinate, even getting out of a chair. All the muscles that you use to get out of a chair, breathe out as you get out of the chair. And then you stand up and you're not so short of breath. So it makes that difference.
What kind of patterns are you teaching people? So what ratios of?
The patterns I like is the standard. It's like, you breathe in, breathing out is twice as long as breathing in. Bottom line, you want to do 2 in, 4 out. I personally like 4 in and 8 out. I also, with my relaxation breath, like to do a slight hold. And this is those years at Mass General that I worked with some patients, and we would be evaluating their diaphragm function if something was wrong. And you could see that sometimes on x-ray, that when you hold, not bearing down now, but when you just hold your breath gently, you can got good distribution of flow out to the distal parts of the lung.
A pause.
A pause. A just beautiful, not a bearing down, but just a beautiful pause. And so then you can get better distribution, get more oxygenation, and then breathe out. And you want to breathe out with a mental count of 6 to 8. And you want to breathe out if you have COPD or any type of lung disease with pursed lips. It's those. Years ago, there was a wonderful artist called Netta, Frank Netta. You might remember.
Netta, sure.
Right? And in his pulmonary book, he made it the clearest. He showed how that when you pursed lip breathing, you created back pressure in your cheeks. Well, that back pressure made it so you didn't collapse your small airways in your lung. Well, what was that now? That's BiPAP or CPAP. I mean, it was just increasing that FRC a little bit in that lung volume. So it's great, and to explain that to people, you can watch. People will go, or, so I feel pretty strong about that. The only thing about the breathing exercise is that, and that's we can talk about that when we talk about yoga a little bit. There's a little difference. But mostly it's really teaching and then coordinating some movement. So we'll do this later, but you want to do movement with the breath, because you want to stretch the chest muscles, the shoulder muscles, the back muscles. You want to coordinate them with the power of that breath. And it's very easy to forget. There's no doubt. I'm always thinking my mantra is keep moving, and my other mantra is lift chest so the shoulders go down. Yes, thank you very much for sitting up nice and tall. So the key is this doesn't do anything. I don't know if you can see me, but I'm slouching over. When your shoulders get pronated forward, you basically get a restricted lung disease. So what you want to do is keep that chest luff up and the shoulders drop down, so you really can use your whole lung volume.
Gotcha. Can you tell us a little bit about, you mentioned that you'd see patients without referral. What kind of screening do you do, and what would you recommend people do before beginning any type of exercise program?
Well, I think I'm very blessed where I am, because if anybody's a patient at Memorial Sloan Kettering, I obviously have access to all their chart, and I read their chart. If I have someone that comes in that is a bit difficult, and I've had quite a few that come from the community or a different institution and want to exercise, what I'll do is I'll go through a quick assessment. I'll ask them about their disease, ask them, what's going on and what medications there are. That always gives me a really clear understanding of what medications they're on. And then with a private, it's very easy, because if I see them privately, I can really watch them, what they're doing. I monitor their breathing pattern with what they're doing. Are they using neck muscles to breathe? Are they using chest muscles to breathe? Is their abdomen moving with their breath? Or then, I'll just do some testing with them. I can see how flexible they are, or do the step test. If they're in a class, and because I do so many classes, I bring them and I sit them in the front of the class next to me, so I can really monitor them. I've had patients with Parkinson's, I've had patients with neuromuscular disease, I've had patients with difficult, stability problems. I have people in my classes that are up to 92 and have walkers, but I just make sure that I really monitor them and look at them. So if they came into me and there was a disease that I just didn't know, I would really check with I'll call their physician. I'm not, hesitating to do that, but I don't need a actual physician referral. So I'm
And do you want a stress test before, or are there people you'll send back for a stress test?
If I know they have some really bad, severe cardiovascular problems. But usually by that time, if they're coming for exercise, I would hope that they had that and I'm looking at it.
Gotcha. And within each session, are you monitoring vital signs? Are you...
No.
What are we doing?
No, it's a little different perspective. It's not being in pulmonary rehab where we're monitoring step by step. I mean, I have to tell you is that what I'm doing is I'm really treating them like they're a normal person, and I'm exercising them. So I really monitor them from what I see. So I do have an oximeter, and I can look at heart rate and their oxygenation quickly if I need to. But that's not my goal. My goal is that they should be reasonably healthy. They should, I take people that are quite sick, but that they're stable, so that I can monitor them in the class or with me privately.
Great. Now you work at Sloan's Integrative Medicine Center, and I just moved in that neighborhood and I saw it for the first time, and I was like, this is perfect. It sounds exactly like what we should be doing with every patient. Can you talk a little bit about how you guys integrate the alternative therapies or the lesser mainstream
Sure.
stuff?
It is a fantastic place. I think actually we're the best kept secret in New York. The truth of the matter is that it's a situation where we look at symptom control for the cancer patient. The patient that has cancer, whether they go through surgery or chemotherapy or radiation or other kinds of treatment, fatigue is the number one.
Sure.
And so we're there for symptom control. So I do all the exercise classes. We do yoga, but we have massage, which is great, all types of massage. We can do acupuncture, because acupuncture is good for
That's
fatigue,
great. I love it.
Nausea, peripheral neuropathy. We have shown that acupuncture is good for lymphedema. So we've really been very blessed.
Relaxing those accessory muscles.
Yeah, relaxing those accessory. I mean, patients come in from all over. I mean, I have to say, my patient population might be 60% of cancer patients from Memorial, and all the others are whether friends of a friend or somebody heard me. But I have patients from all different institutions and different hospitals and from the community.
We hear over and over again when patients are being treated for cancer, whether it be surgical, whether it be radiation, whether it be chemo, a lot of times they're told to rest. Depending upon the institution, they'll either be told to exercise through treatment, wait till after treatment. My feeling is that it's always better to be doing something.
All right, well, you hit this is my goal. My goal is by the time I retire, that every person that gets diagnosed with cancer will get a prescription for exercise the first day. And what will that prescription be? Walk a mile a day or a half a mile a day. Do maybe one flight of stairs a day. Do some arm circles and do 10 chair squats, up and down in a chair 10 times in a row. My goal is to maintain all those large muscle groups. Now, there is a lot of research on cancer and exercise right now. And in fact, I've done a couple of projects myself. And I just wrote a chapter on exercise for the older adult with cancer. The problem is that we've got to keep people moving. When I first started this job, it was just amazing to me that people would go through all their treatment and come to me, and they literally could not sit up. They could not stand up. And you really need to teach and really work with them on that. We are not saying anymore, go home and rest. When you have cancer fatigue, rest doesn't help. It doesn't make the cancer fatigue go away. The one thing that we do know is when you start exercising and moving the muscle and producing different chemicals in the muscle, actin, myosin, that actually takes the fatigue away. And you can read every study in the world of cancer and exercise, and it's going to show you, if it's a randomized trial, that patients that exercise through cancer have a decreased level of fatigue than someone that's sedentary. So I think that the key is to keep moving.
I also noticed that over the last 25 years, I mean, when we first started in '92, I mean, you had chemo and patients were wrecked for days after chemo, and radiation, same thing. It's gotten so much better as it's become targeted, and so people really are able to work through these things if they're given a little guidance.
I think that what the key is that I think we're finally saying, just not go home and rest. I think that we're realizing you see overall that the patients that exercise, and it doesn't even matter that it's cancer.
In everything.
It doesn't matter that it's cancer. It matters that it doesn't matter what illness you have. If you keep moving, you maintain flexibility, you maintain a quality of life. If you stop moving, let me backtrack and say this. In your 50 decade, you can be an active person, but you're still going to lose 0.5 to 1% of your muscle strength. If you don't, and then when you get into your 60 decade and your 70s and 80s, if you don't exercise, you lose muscle mass really fast. And it just happens. This is the aging process. So my goal is I'm in my late 60s and I'm going to fight it all the way. So, and I'm working at it as hard as I can. But the truth is,
I wish I had biceps like that.
But the thing is, you have to keep moving, and exercise is the key. Now, what is the big hard part? How do we motivate people to exercise? How do we maintain them to adhere to exercise? That's the hard part. And I always feel that I feel very passionate about this because I want to motivate people. Because I know that I have seen from lung transplant patients to lung cancer patients to women after other cancers, anything. It could be a trauma person. It could be someone after a neuromuscular disease. If they get back and exercise, they have a better quality of life. And I'm blessed because at Memorial now we have a doctor who's looking at the biology of exercise, looking to see that if you exercise, could you then decrease tumor growth? We're in that infancy stage. I know it works. I've seen people with stage 4 disease be with me for years and exercise, and they look better, and they go back to their oncologist, and the oncologist says, well, I don't understand. Why do you look so good? Well, I'm exercising. Oh. And now they're starting, it used to be like, oh yeah, right. Now I think they're listening.
I think they're getting the message.
They're getting the message. Mm-hmm. I think they're getting the message.
I say to people a lot, it's like if you could walk a mile today, you can walk a mile tomorrow. And if you could walk a mile tomorrow, you could walk a mile the next day.
Right.
But what happens, unfortunately, is people can walk a mile today, and then they may not walk a mile for 30 years. And then they come and, we see the lung function is the same and the heart function is the same, but they're much more short of breath, they're much weaker, they're having a much more difficult time with activity. And what is the difference? Obviously, it's the exercise.
It's exercise, it's
or
muscle.
the lack of it.
A lack of it. It's muscle deconditioning. It's that, you hate to say it, if you don't use a muscle, you lose it. But the truth is that our body changes. The whole aging process changes. So you really need to exercise. And if you have a disease, we're talking about lung, and I think lung to me is an amazing, fascinating organ because it's such a gravity-dependent organ. It's not a muscle, it's tissue. So if you have a lung disease and then you're not exercising and the muscles of your chest wall and your diaphragm and your shoulders and your back muscles are weak, then everything you do is going to take an incredible effort. So then what happens is you try to go a block and you're like, I can't breathe. Well, you can't breathe because you're so deconditioned. So it's so important.
Let's go to some of your techniques,
sure.
And then we'll go to audience questions, of which we have a lot. And please feel free to ask questions of Donna. So let's start with 4-8-8 breathing.
The 4-8-8 came because, again, we mentioned what about a breathing pattern. I like your inspiratory, your breathing in to be 4. So, and I always like when I do a breathing exercise, I like you to breathe in through your nose. When you breathe in through your nose, you use your diaphragm. If you want to check yourself as you're sitting at home, put your hands underneath your ribs and just sniff. If you sniff, it's diaphragm. It's all diaphragm. So I like people to breathe in for the count of 4 through their nose and just hold the breath. Not bear down, but just hold the breath. And as you hold the breath, I know that the air is getting distributed out to the distal parts of the lung. If I put my hands on your chest wall, I could actually feel your diaphragm kind of moving a little bit. And then blowing out through pursed lips, long and slow for the count of 8. The key is to get the breath out so that you get a better breath in. You know, people say, well, I got to breathe in. I have to breathe in. You know, the lung pressures are fascinating, and the physiology of the lung is very fascinating, because what happens, you breathe out, but the change in atmosphere pressure and your lung pressure, air just goes right back in those lungs. So that but you need the effort of using those muscles to squeeze the air out and get a better breath in.
Now, what about our patients that are sitting at home that are saying, there's no way I can hold a breath for 8? How did they get started?
They just hold it then a shorter time.
And should they adjust the inhalation as well?
Yeah, or you could maybe breathe in for 3, hold for 5, and then go out. I think the people that have lung disease are always afraid, hold. You know, I can't breathe. But remember, you're not bearing down. If you bear down, then there's no flow. Then you won't breathe. But you just then start at a slower pattern. And I have to say that it doesn't take me long to get someone, and I'm thinking of 2 people that I'm working with very closely now that have very severe lung disease, and that they are like, no, I can't do it, but yet after about 3 or 4 breaths, I can see them breathing in, holding, 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 and then blowing out. And it's your mental count of it. Remember, it's not seconds. It's your mental count of breathing out, 6 to 8.
And how often should people do this?
You know what? If you have people that have a lung disease, I would say I like them to do 4 to 6 breaths 4 times a day. The other breath that I really like, and I used to call it diaphragmatic aerobic breathing exercise. Okay. It was way too long. All my lung patients said, that's not what it is, just call it what it is, sniffles. So I'm going to sit up a little bit here, and just so you can see. But if you're putting your hands underneath on your diaphragm, and what I want you to do is just breathe out very slowly. Let's do it slowly together. Breathe in and out of your nose. That's all diaphragm. So your goal with that is, if you want to make it aerobic, is you do it faster. So you can work on that on your own. You start off with 5 seconds, you start off with 7 seconds. And the feeling is that if you can get up to do 30 to 45 seconds of that pretty rapidly, your diaphragm's pretty strong. And it really makes a difference. You know, years ago when I used to wean patients off the respirator, I always could tell what the strength of the diaphragm was by doing those inspiratory pressures. And it was great, because you'd know, I mean, all of us that are relatively healthy, we have a negative inspiratory pressure of probably a -20. I used to wean people off with -2. There was nothing. And then when it finally got up to a -40, I could take their breathing tube out. But it shows that was diaphragm, that I'm looking at the pressure of the diaphragm against that. And that's, you know, it's funny, you've asked me a lot of different questions, and I think about my life as a nurse and a personal trainer and a respiratory. But it's like, then I look back and think, oh my gosh, I did this. And then, you know, when I did my master's in nursing, I found swallowing with trach tubes being fascinating, so I did my research on swallowing, because swallowing is such a common problem with lung patients. They aspirate a lot, and what happens is when they aspirate, things go in the top, right above your vocal cords. You have 2 little pockets, and then the stuff gets caught there, and then they turn their head and they start coughing. Word to the wise with all lung patients: when you're swallowing, especially water, especially liquids that are easy, chin down and swallow, and you won't cough as much. But yeah, that's what's been making my life so exciting, because you grab from all the different aspects of my career, and you put it together, and it makes it so I can help so many people.
Well, as I mentioned before, I looked at your literally 25-page CV, and it's like you've done everything, like literally every single inch of the respiratory system, and it's fascinating.
It is fascinating.
It's really,
and it is. And you know what? There's not a lot of us around. I'm going to be honest with you.
Yeah.
I just got a call from the Lung Cancer Alliance group. They want to do a whole thing on breathing, and they go, "Do you know anybody else that's doing it?" And it's hard. I'm always amazed that I am having to teach nurses all the time about how to breathe, what to breathe, how to, I just had a woman that had, lung surgery. And how do you get out of bed? Hold your incision,
Sure.
Splint your incision, breathe out. So it's kind of like, it's fascinating, but I always found that people are afraid of the lungs in a way, because when you're short of breath, what do you do? And I think what it was is that when you're short of breath, your lungs are overinflated, because you're like, how can it's trying to suck the air in, when in fact, get the air out.
And do you think that's the same mechanism with the restricted patients, with someone with pulmonary fibrosis? Do you think
it helps? They're
still becoming?
It helps. I mean, I have people that write me back and always say, it worked.
Okay.
So I think that I really do believe it works. I had someone that had pulmonary fibrosis, COPD, and lung cancer. Okay, all three. And I think that some patients might appreciate you hearing this, but I went to see her and she said, well, what are you going to do for me? I'm like, well, I'm going to try to help you a little bit. So she goes, I can't walk. I'm like, okay, I'm sure you hear that all the time. So I let her do what she was walking, then I asked her to walk the way I would tell her, is just blow out with each and every other step, just blow out gently. Long story short is I taught her a lot of breathing exercises and how to manage things, getting out of a chair, getting out of a bed, doing this. And when she went to her pulmonologist, she said, would you come with me? And I said, well, sure, why? And I mean, I knew the pulmonologist well, and I didn't know she was going to do this. And she goes, how many years have been coming to you? So, well, many. You give me drugs all the time. Another inhaler, another drug. You never taught me how to breathe. She taught me how to breathe. And that's part of it, is that you really take what I'm saying and take what Noah is saying to heart, is that you need to learn how to breathe correctly and utilize the power of the breath and utilize the lung function that you have to the best of your ability.
What's so interesting about this is, we, in the forums, okay, and I'm in many, okay, we hear the same thing over and over again, over and over again. I get short of breath when I bend down. I get short of breath when I walk upstairs. I get short of breath when I take a shower. And it's the same thing over and over again. And we wind up like reinventing the wheel over and over again. And somebody then says, hey, I have an idea. Crack the bathroom door when you take a shower. Wear your oxygen. And it's like, yeah, but we've all known this for so long, but it somehow doesn't get transmitted to the patient.
No.
And that's one of the tricky things. Talk a little bit about the thoracic mobility, stretching the muscles of the chest, and what kind of exercises you recommend.
Sure. You mean in general, not after surgery or anything, but just in general?
Yeah, general. What are the problems that someone with COPD or pulmonary fibrosis might encounter, and how do we prevent those?
Well, I think the key is that think about your chest wall. Everybody worries about the chest muscles. Unfortunately, this muscle in the front, your pectoral muscle, likes to pull forward. So in forward, then you have to lift the chest. And the truth is, I'm going to stand up here a little bit again.
Sure.
Is that if you put your hands like this, or if I even turn sideways for you, you can see my shoulders are slightly pronated. But if I take my hands and put my thumbs out and my thumbs back, it rotates my shoulder back. It lifts my chest, and now I'm going to open my chest more. So the goal is obviously not walking down the street. You'd look a little funny, but the truth is to just keep your palms back, and when you're doing a shoulder roll, so that you can open the chest. So my goal is that not to really build up the pectoral muscle very much, because that's going to pull forward.
Sure.
But The muscle that you have in your back that's under the shoulder blade to the middle of the back and lower is called the latissimus dorsi. So I always have giving exercises where I have them up and pull down to a W so you can get that strengthening. You've got to strengthen the back muscles. So when you strengthen the back muscles, it gets the chest lifted and the shoulders down. You don't want the shoulders to rise because you lengthen the muscles of the chest wall, then you have no stretch of flexibility. So you really want to lift chest, shoulders down. And that's something that you have to work at because you're so used to being in that sort of kind of stressed, overstretched position. So the first thing I could say is lift chest, shoulders down, palms forward, do a shoulder roll or two, and see how that feels. I have an exercise that I'll show you in a bit that it opens up the chest remarkably, and you're not doing anything. It's very easy, and we'll do that. But you want to strengthen. I don't want you to strengthen here. I want you to get your shoulders strengthened because I want you to be able to pull. I want your neck muscles. Now, some people are very dominant with their neck muscles, but weak at their mid-back. You really need to relax the neck because when you get short of breath, it's like you're pulling up this way, right? So you really want to get them to get their lats more engaged,
Sure.
and then this way their whole upper body will be stronger.
And so much of what you're talking about is postural. You know,
Yes.
it's
Yes.
what people don't realize is that because as human beings, most of what we do is in front of us, these muscles get very tight, these muscles get very loose, and what we're trying to do with people is we're trying to correct imbalances. And how do you correct imbalances? By relaxing or stretching the tight muscles and by strengthening the weak muscles, which is why, when we do things like upper body, we're always going to focus on the back muscles first. Again, you can go to your next exercise now if you
So
want.
the key is that there's an exercise that I've done, and I can just I'll make believe with this tissue. Say you have a dish towel at home. I'm sure everybody has a dish towel, right? Mm-hmm. I hope so. So what I want you to do is you take your hands and you put your palms towards the buttocks. Okay? And what you do is you now, with this, straighten your arms. Now look what it did. Oh my gosh, she has a towel. That's even perfect. Thank you, Noah. So you take the towel, okay, and you put your hands towards your buttocks. Now, take your hands, and you might have to start wide, and ultimately you'll come closer together. You put your arms straight down. Now look what it did to my chest. It opened my chest. Now, in this position, you're squeezing all the back muscles, so actually they're all in contraction, so you're making them stronger. And with them making them stronger and opening the chest, you take a couple of nice big deep breaths. So simple, but so rewarding. And if you did that 5 times a day and held this for 15 minutes, it won't hurt so much. The first time you do it, it may hurt a lot because you're really contracted forward. But it's such a simple exercise. After lung surgery, after breast surgery, after any kind of restriction, you go like this. I did it to a woman the other day. She was totally surprised. She was like, "Oh my God, I haven't stood up like this forever." It just works. So, and then you want to exercise shoulders, that kind of stuff, but you want to then coordinate the power of the breath with it, So I think that's what's important.
And then just one other point I want to add is that, when it comes to these different postural things, doing these for 15 minutes or 30 minutes a day, it's going to help you, but it's not going to correct the other 23 hours and 30 minutes. So you really have to be aware of your sitting position. You have to be aware of your position when you're in the taxi or driving or at your desk, and, stretch these things out, because consistency is the only way that it's really going to be effective.
You didn't get there. You got there because you were this is a very safe position. People like this because it's safe. It's not safe. It's causing you to have restricted lung disease. It's causing you to just kind of cave in. This is really what you want. And even if you sat in a chair one day and put your hands behind your back and stretched your chest forward, anything you could do. And that's one of the things that, even on the video, that I did with YouTube, I talked about why and how you breathe, and I talked about breathing exercises, and then I do some exercise with that. This exercise I feel really strong about, and I know some people know what I'm going to do. This is a very simple exercise. I believe that you could start doing 2 of these a day, and ultimately everyone should do 10 every morning. The first thing I'm going to say is you never get out of a chair from sitting in the back of the chair. Because when people come to me, I have bad knees and I have a bad back. You need to use muscles. So what the first thing you wanted to do is go to the first part of your chair. So you're right at the edge of the chair. You're not going to fall over. Your knees are going to be hip width apart. And what I want you to do, it's called a chair squat. And all you're going to do is you're not going to hold on to the sides of the chair. You're going to use your strength, your breath, and squeeze your buttocks. So what I'm going to have you do is breathe out, squeeze, and stand up. Now you can put your arms over your head for a stretch or just come down. But you just come up and breathe out. Now, I would tell you, you could do about 3 or 4 of those and say, woo, that's really tiring. Because you're using those large muscles of your legs. You're using the shoulders. You're using your back muscles. You're using everything. This chair squat is the simplest. We have steps everywhere. We have getting on the bus, getting in the car. You need to use your leg muscles.
Absolutely.
So that's why it's so important to not only do, some cardio workout, but to do some very basic exercise. So the chair squat is something that I think everyone with any kind of illness should probably do 10. Get up in the morning, you get into the kitchen, you're waiting for your coffee or tea, do 10. You've stimulated your heart rate up, you got your heart rate going, you're gonna feel brighter, you're gonna wake up, and you're gonna feel better.
And as Donna says, if you can only do 3, do your 3, and then take a break, and then do another 3, and then do another 3, and it will build. These things, in the same way that you can spiral downhill, you could spiral uphill as well, and that's what I think so many people don't realize, is they get into this mode where, I'm just getting more and more short of breath and weaker, and they don't see how they can put the brakes on that. Right,
and I think that you feel sort of overwhelmed, and you feel like, oh, I just can't do it. Really start slow. And you know what? The muscles are very interesting, because you know what? You are consistent with the muscle. You exercise that muscle consistently, and it will get stronger.
The last thing I want to ask you before I ask you if you want to add anything, and then we'll go to audience questions, but can you talk a little bit about recovery from shortness of breath? So what I call the code red situation, which is where people are walking in the street and all of a sudden they're gripped by that shortness of breath and they feel like, Sanford and Son, this is the big one. Right. What can they do in that situation?
I think that the most important thing is, if you can find somewhere to sit down, obviously sit down, because when you're standing up, remember, when you're standing, your spine your spine is working and all the muscles are working to hold you upright. If at least sit down, you take the relaxation off the large muscles of the lower body. The key is that I see when people get short of breath is their head goes up and they start going, breathing in. Now, this could happen in the cold weather. This could happen in the wind. It could happen, in the heat that has been so hot this summer. But the key is that what you want to do when you feel that you got that panic and that really feeling of shortness of breath is take your chin and put your chin down. By putting your chin down, you relax the muscles in your neck. And when you relax the muscles in your neck, it's not going to pull. This big muscle in your neck here pulls on the clavicle and the first and second rib. So it pulls up, but it doesn't help everything down here. So if you put your chin down, as I have explained before, and just breathe out. And it could be short, fast, quick, short breaths. Keep the chin down and keep blowing out. And then when you feel that tension around the neck going away, which usually happens, is then breathe in through the nose, blow out through the lips. Breathe in through the nose, blow out through the lips. And then once in a while, when you just feel like you're doing okay, lift your head, breathe in, and do not care who's around. You just go, ah. Now, the interesting thing about the is that the air is coming from the lungs up through the vocal cords. And again, many years ago when I used to do bronchoscopies in Boston, I could see that when the air comes up through the vocal cords, your vocal cords are going open, close, open, close, open, close. So it's letting a little air at a time. So what happens is it's sort of like this big sigh. And with doing that, your heart rate goes down. And as your heart rate goes down, your airways will open up. And I mean, I have seen this more than once, many, many times when I've worked with people with a panic, and I have the oximeter on, and their oxygen saturation is 78%, and their heart rate's 120, 130, and they're like huffing and puffing, and and they want very much to keep their head up. I keep their head down, and I really literally take over what they're doing in their head. So I'm constantly saying, breathe out. Breathe out. So I want to control their breathing pattern. And then all of a sudden I can feel everything loosening up because everything's relaxed. You know, because there's receptors in the lung, and most of them are up here near this area here called the carina, but there's receptors and they like tighten up, and then the airways tighten up. The bronchioles will tighten up. So it's really that healing breath, and I know it works. I've worked with numerous people to know that. So it's something to remember, that the power and the important thing is to breathe out until you feel like that tightness goes away from your neck. Then breathe in through the nose, out through the lips, in through the nose. And I know I've said this a few times, but I know how important it is. The last thing I'm going to talk to you about is stair climbing. Stair climbing is everybody, let me put it this way, when I did some research at Memorial, and I took the patients up, and they looked at me and they said, oh, I can't go up those stairs. I'm like, you can. Anyway, they would go up the steps their way and be short of breath. My way is, every time you go up a step, your body weight plus gravity is pushing you down on that step, so, and then you're pushing down again. And you push down again. You breathe out as you go up each step. Those patients that I did some research on that were pre-lung surgery with severe to moderate to severe COPD, I wouldn't take people that were mild, they had moderate to severe COPD, they all increased their stair climbing by about 150%.
Wow.
By practice. So I know that I've been talking a lot. I'm sorry, I get a little passionate and very excited.
That's why you're here.
But I also wanted to say hello to everybody that knows me. I feel honored that you're on the webinar. I know that there's a Becky that I know and I remember well, and thank you for being on there. And hopefully we have some questions.
Let me ask you one more thing, because
Sure.
you just said that you don't take patients with mild COPD.
Oh no, that was for the research.
Right.
Just for the research.
Okay. When do you think somebody should start exercising with COPD? So do you believe in you're not sick enough for exercise, or you're too sick for exercise? Because that's something we hear a lot.
Oh, no. Let's be honest with everything. If you know that you have a component of chronic lung disease, whether it's bronchitis or emphysema, whatever, or restricted disease, is it because you were exposed to environmental things or you were a smoker? The bottom line is, you're going to have changes. Don't wait till you're short of breath.
Exactly.
Don't wait, because by that time, then you're coming to me many years later saying, well, I wasn't short of breath, I could do everything. But, could you really? And, when that doctor gives you that first inhaler, that's your time to say, I have to do it. Now, I have someone to show off about today, and that is a woman who had lung cancer, and I actually have another friend here that with the same situation. She had her right lung removed, part of her right lung removed, and part of then the whole lung removed for cancer. She came to me absolutely breathless. No one knew what to do with her. They couldn't believe it. Now, obviously I worked with her and we got through. She now runs around the reservoir in Central Park.
Wow.
I mean, at her pace, but she can run around. And she has her left lung. And her left lung, as the doctor said to her, you are using every air sac possible. And it's been remarkable. And she exercises, she does weight training, she does, treadmill walking, and she goes outside when so it can be done. Because I have honestly heard from people, oh, I had a lung removed, or I had a piece of a lung removed, I can't do that. No, sorry, no. I can tell you that we've done pulmonary function tests on people that had one whole lobe of a lung removed, and actually minimal to no change
Absolutely.
in their PFTs.
Well, there's so much redundancy.
Yeah.
People are like shocked when you say if we lay the lung out, it would take up a tennis court.
Yeah, I know.
I mean, there's so much redundancy. But, you can get your mind into that. Wait, I only have 2/3 of my lung left. I'm probably going to be a third more short of breath.
Right. Yeah, and that's what you have to get out of. You have to modify maybe a little things, but you have to, even if you don't, you have to modify. But if you modify, then you can change what you're doing and then be able to do the things you want to do.
And one thing I want to add to that is that, we talked about this, but so often a person will have a lobectomy or a pneumonectomy, any type of lung surgery, and the doctors will say, well, just walk. You don't really have to exercise, or you don't need rehab. And what my experience with that is that we've been trying to get some of the thoracic surgeons in New York to refer like a week or two after surgery, because then we can change the modeling and how the lung actually heals and prevent a lot of that scarring down. And what happens a lot of times is if you listen to their lungs like a week or two after surgery, they sound great, they're not short of breath, but then 3 months later, because they haven't been moving or because they've kept their arm in one position because of pain, now you have decreased breath sounds. Now you have rails at the base. Now they're short of breath. And we have to spend the first month and a half undoing the sedentary activity because they weren't doing anything.
Well, it's a funny thing, because that's the problem. And I think as it's getting there slowly but surely, and there are times that I am a little frustrated that people don't talk about exercise. A physician doesn't talk about exercise. The truth of the matter is, you've got to be as mobile as you can. You never, after any lung surgery, want to hold yourself still. I want you to get up and over. You've got some scar tissue in here, or wherever your surgery was. You've got to get that scar tissue kind of flexible and moving. Scar tissue is very hard to mobilize. It gets really thick and very fibrous. But still, there's no reason why you can't get the flexibility back in that shoulder because of you be having lung surgery, unless you had a very specific problem. And if you don't move, then you're adding to injury by having a rotator cuff injury. But there is no reason, and I would agree with Noah, that people after lung surgery should probably go to rehab. And it might not be, I would say that I would give them those first 2 or 3 weeks home, and then say a month after, because that's the critical time. A month after their surgery, they know they're okay, they've had their x-ray, they know everything's okay, they should enroll in a rehab program to get themselves in the better quality of life, and then get in a routine right away so they don't slump down.
All right, awesome. Let's take 1 foot move over to the left, and then we'll go to questions.
Okay.
All right. So question number 1 from Jerry: should O2 be increased for exercise? Also, how about using a rescue inhaler prior to exercise?
It depends. If you have a bronchospastic component to your lung disease, yes, use the inhaler before some vigorous exercise. It depends. I would rather know if your oxygenation is normal and you're on 2 liters but what is it when you exercise? Mm-hmm. So you really have to have, whether you go and do a walk with a nurse or you have someone check your oxygen when you're doing the activity, you may not need it. I don't think more oxygen doesn't mean you're better.
I agree. I mean, I think you have to use the numbers. It's like I say with pilots and scuba divers, they can't tell what's real. They have to use their instruments, and you can't always tell what your saturation is. So a lot of times people think their saturation is low. It's really not. So if your saturation is low, by all means increase the oxygen. If it's in the mid to upper 90s, then the oxygen's not going to help you. So it's like redundant. So, all right, I have MAI, a chronic lung infection. I already took the 3-drug cocktail, and by all means, if there's any questions that are out of our scope or you don't feel comfortable, we're gonna say that as well. I have MAI, a chronic lung infection. I already took the 3-drug cocktail for 18 months. I got some benefit, but plateaued. Infection was not eradicated. I am easily short of breath, especially when walking up even the slightest incline. What exercises might help me?
Well, a lot. I mean, I think first of all, you have to learn how to walk up that incline. So when you are walking, I usually tell people if you're on a flat surface, just breathe in and out of your nose. But if you're going up an incline, think about what you're doing. If you're going up an incline, you're using different muscles. You're using your buttocks, you're using your hamstrings, you're using your quadriceps, your leg muscles, those are really big muscles. So they're going to take a lot of oxygen. So what you want to do is breathe in through your nose and blow out through pursed lips as you go up that hill. The exercises that you have to do is you want to strengthen your diaphragm and you want to strengthen total body conditioning.
Absolutely. Here's a question from Linda. I have a flutter exerciser. Should I not be sitting up when using it, but get horizontal for best results? I'm going to just take this if you don't mind.
Sure.
The thing about the flutter is really one of the first positive expiratory pressure devices that was used for secretion clearance. And unfortunately, you have to hold it in that position for it to work effectively. As things got improved, we saw things like the acapella and the aerobica, which are not position dependent, and those things are great because you can get into the drainage positions, as Donna mentioned, and those things work perfectly.
Yes, I would agree with you 100%, yeah.
Okay, any specific concerns about, this is a great question, this is a fascinating question. Any specific concerns about reinfection by aspiration if patients are in the upside down positions to expel phlegm? I am an NTM patient and very concerned about reinfection because treatment is so toxic and often not effective. That's a great question.
It's a great question. The most important thing is that if you feel there's anything in the back of your throat, there's a lot of GERD or reflux or whatever, and what you want to do is really cough it out. Now, I'm going to tell you something. When you cough and you're in that drainage position, you really don't start mobilizing the phlegm until it gets to about here, this is the bifurcation of your right and left main stem. In the carina is where you have all your receptors, and that's when you start to cough. But the key is when you cough it out, really try to, if you can't get it, then huff it out. So what is huffing? It's an old way we used to do it, and when I did my chest PT, was you open your mouth and you huff it out. Now, I'm going to show you one more thing, and it's not pretty, and it doesn't sound nice, and it's not polite, but right above your vocal cords, you have two little pockets. Those pockets are the vallecula and another sinus right here. Stuff gets stuck in there. So then all of a sudden you turn your head, the stuff goes down into the vocal cords, and you're afraid of aspirating. So what you want to do is after that, if you cough and you huff and you can't get it out, all right, I'll do it, even though it's on camera. You have to hawk it up. I know it sounds awful, but it works. I'm just telling you what really works after all these years.
I feel like we're in the Catskills in the 50s again. And you just had like a pastrami sandwich.
Right, exactly. But it's true, but it just makes a difference. You've got to clear the stuff that's above the vocal cords. Because what happens is once it goes below the vocal cords, you can feel your Adam's apple right here where the vocal cords are. Above here we can tolerate a lot. Once the only thing that the lower airway will tolerate is normal saline. But any kind of food particles, other phlegm, anything that gets down there, you go into a real big coughing spasm. Now that's a scary thing, because I can tell you that if you get to the point of really being that scary, when your larynx is doing that, it's a difficult problem. I mean, you really have got to have somebody with them and blow out and really get that air going, because the larynx can spasm a little bit.
You know what I think is a great improvement over the years? I notice so many pulmonologists now are including like a gastroenterologist consult automatically as part of their care, and how many doctors are saying that reflux and GERD, treating GERD is like so crucial, like the number one thing to do when you have lung disease, because the GERD makes the lung disease worse and the lung disease makes the GERD worse.
And chronic slow infections, chronic slow aspiration is going to be a chronic infection, and you're going to get chronic bronchitis all the time. It can even help when you have really bad sinuses.
Mm-hmm. Here's a question. I've started wearing compression socks to help with leg edema. Is it bad to wear them? Should I curtail the amount of time that I wear them each day?
It depends why are your legs swelling. So the first thing we have to look at is did you go to your doctor and did they do an echo? Did they do a stress test? That your cardiac function is normal. It's not like you're having any, mitral or aortic regurgitation. Mm-hmm. So you want to make sure cardiac function is good. You want to make sure that you're not excessively using salt, because that can happen.
Sure.
And one of the things that's very helpful and it's very good is that when you get home and you can put them on, and you leave them on actually when you're active and up and about. You should take them off when you're going to bed, obviously. But the other thing is, if you take your legs and put them up 45 degrees, if I just mimic if this was my head and this was my hips, my legs are up. You don't want to put it up like this because then you're going to decrease the flow. But if you put your legs up about 45 degrees, hold them up there for about maybe 6 or 7 minutes, you'll see that the fluid comes down. Pump your ankles a little bit because the calf is your heart muscle of the leg, and it'll kind of pump that fluid out, and you may get the fluid out that way. But you really have to make sure you have no cardiac involvement.
I'm just wondering, when you're showing these little demonstrations, are you particularly trying to flex your muscles?
Sorry.
All right.
I'm proud of my muscles.
And you should be. I would be proud too if I had those muscles. The only caveat I would say is the congestive heart failure patient has to be careful with being tipped and with putting their legs up, because that's also going to increase the workload on the heart. So for those people who are like teetering on the edge, just use caution with that.
Or just use caution. Or just put them up on 2 pillows. Don't be up at that high.
I used to have no problem using 5-pound hand weights, but had an exacerbation last winter and my lung wall seemed to hurt. Now I'm afraid to start in on weights again because it seems to increase the chest wall inflammation. How do I proceed?
Well, the question really is a little, my question to you is that, did you have a pleural effusion, and did they didn't do anything to your chest wall, your lung? If you could answer that question, because if you had, sometimes what happens if with a big lung infection, you could have had a pleural effusion, they kind of drained out the fluid in that area, and sometimes they put a medication in there, and we put the lung so it sticks up to the chest wall. And that really makes you feel like you can't expand your chest wall, even though you are. So one of the things that I've done, and I will use this trusty little towel, is that you can go around and put this towel around your back. Okay, you can take this towel, so you want to feel like you want to move that chest wall a little bit more. Is that's the question right now? You take a towel and put it around, not below the ribs, because those 2 ribs below here are floating ribs. So you don't want to; they're not attached to your breastbone. So you come here and you put this around. Now you cross your hands. Okay. So now what you do is you take a deep breath in. And you get expansion of that chest wall. Now you breathe out and pull on that towel. Now, before you breathe in, release the towel. Breathe in and blow out. So what you can do is you try to sort of compress that chest wall. You could do it with your hands as well. Put your hands under here. And as you breathe out, push down on your chest wall. Now, let go when you're breathing in. Breathe out, push down, push down, push down, push down, push down, then breathe in. You'll start to stimulate, there's little receptor sites between your ribs called J fibers, and what in fact you might be doing is really stimulating them to open up the chest wall a little bit more. But that really just with the towel works very nicely.
It sounds also like she might be a little bit afraid. And one thing, when people talk about inflammation or chest discomfort, there's so many systems in between here that a lot of times it could be cardiovascular, it could be respiratory, it could be musculoskeletal,
it could be ribs,
it could be GERD.
Right, it could be like a little chondritis between their ribs and stuff. But the key is don't be afraid, because the thing is put your hands on your chest wall and close your eyes and feel the chest moving in and out. And then just sort of put a little gentle pressure or open up, or just try to take the biggest deep breath you can. The other thing is try very hard. One of the things is what you want to do is, if you want to increase lung volume a little bit, another breath, which I used to call the snow angel, is you put your hands out to the side, but breathe out when you go up, because you want to decrease lung volume to get more flexibility of the chest wall. So try that, because that might give you a little bit more flexibility, stretching up, breathing out. Just think of the old-fashioned when you're down in the snow and down. So breathe out, arms up over your head so you can stretch. You don't want to take a breath in, fill the lungs up with air, and then get your arms up, because you can't move. So you really want to breathe out and just put the arms up over the head and back down, so you can get that kind of feeling of flexibility. It might be the fact of being afraid to move, the muscles shorten and tighten.
Exactly, especially if you had an exacerbation. I mean, if you think about it, if you spent a lot of time in bed, less active, you're not going to be taking as deep a breath, and there are muscles in between the ribs, and those muscles get tight in the same way that any other muscle might get tight. So now that your exacerbation is clearing up, you're now needing more activity, you're now needing that deeper breath, and maybe tight muscles is the reason that you're feeling that inflammation. Maybe your ribs are just, pushing on each other. So I agree.
Yeah, well, between the ribs, you've got two sets of muscles, the internal and external intercostals. And so you really want to, get them moving. So you want to open the ribs a little bit.
This is not a question, it's a comment. Donna is just brilliant. Really enjoy her. That's from Bill.
Thank you.
Here's a question along the same lines. How do I find a trainer like Donna in my location?
Where are you? Is the question.
Where are you?
It's very, I have to be honest, I know that I'm unusual. I mean, Noah and I are kind of, really lung experts, and we enjoy it and we like what we're doing. What I probably would ask you to do is you can't go to a regular gym and ask. I mean, you just can't do that. What you have to do is ask somebody that, in the area. You could check with a physical therapist. Sometimes some of the physical therapists, might have rehab or be better at lung. If you know somebody's a physical therapist that has done chest physical therapy, that would be excellent. Or there are some respiratory therapists that are very good.
I mean, cardiopulmonary, unfortunately, is still the weakest link in physical therapy education. And it's going to vary depending upon what school you go to.
That's true.
But yeah, make sure you're with the right people, because if you're with the wrong people, you can wind up getting hurt. So your guns are amazing. Thank you. I appreciate that.
It's hard work.
It is hard work. Now, here's a question also from Bill. What do you think about things like Qigong and Tai Chi?
I think they're great. Listen, we all have, I think Qigong and Tai Chi are for balance and flexibility, and it's great because you use your breath at the same time, and I think they're terrific. But again, it's not as much muscle strengthening. So yes, I would use it as an adjunct. I would use it as to use the power of your breath, the stretch and the flexibility. I actually have gotten even away from a lot of what we call static stretching, where you stretch something and hold it. I do a lot of mobilization stretching with people now, because I find that it's much more effective. Like a great exercise for all of you to do is something very simple. One hand out, you do a figure eight. So you make a figure eight with your arm. Now that seems like a really simple exercise, but you're using your pec, you're using all the shoulder muscles, you're using all of your upper back, and you loosen them up nice and easily. And it works much more effectively than just holding a shoulder.
Are you familiar with arm size? Do you do arm size at all? Okay. Next question. Hi, Donna. Which specific exercises work the chest wall muscles most efficiently? Hi, Sylvia. I'm sorry I came in. Yeah, there we go. Which specific exercises work the chest wall most efficiently?
I think about it. You can do a shoulder press, you can do a chest press, a lat pull down, and a pull back. Those four are the really key ones, because the shoulder press is going to get arms, chest, back. The lat pull down is going to get your back muscles. This pull back, squeezing your shoulder blades into your spine, is going to get your back muscles. And a chest press here. But again, remember, I don't want you to build the chest up as much, because when you build up this pectoral muscle, it pulls the shoulder forward. And if you pronate your shoulders forward, it's going to decrease your lung volume. So my goal is that would be the last I would do, just to maintain some good strength of that muscle. But the lat pull down, pull back, and a shoulder press are the key.
Okay, I have severe COPD and really have decompensated so much that my O2 sats dropped to 86 during the 6-minute walk test. There is no pulmonary rehabs in my area. Would going to a general exercise program such as a Planet Fitness and Just Start be effective for me?
I think you have to ask them, if you could go with your oxygen. Some places, it's a liability, so you have to, I think it's great. I think that, think about this. There's a lot, even if you wanted to go to Planet Fitness, you're not going to get someone to tell you what to do. You could even go online. They make now this new bike I saw that you could just, do some leg exercises and stuff, and just do bike exercises and probably use it for your arm, like an arm ergometer. I think it's a little hard thing because, God forbid if something happened and you had severe COPD and you went on the treadmill and you were standing. I guess if you did go, I would tell you to use the recumbent bike. That might be the safest because you're sitting. But I would feel very careful that you really have to learn to, have someone there be comfortable with you.
Absolutely. And also, really good medical workup ahead of time. One thing about patients with respiratory disease and underlying cardiovascular disease is that a lot of times heart disease is missed because you're limited by shortness of breath and fatigue. So a lot of times someone will come here and they, prior to starting an exercise program, they don't actually get up to a workload that elicits the cardiovascular defect.
Very true.
And because they get short of breath. So, maybe they get short of breath at the 5th step and they stop and rest. Whereas had they gone up to that 8th or 9th step, they would have found out they have heart disease. So, a key component to any exercise program is get a good clearance. At a minimum, a stress test, and ideally a stress echo, just to rule out coronary disease that you don't know about. Okay, so what is your recommended breathing method during exercise? When I'm on the treadmill, I find that I breathe more rapidly.
Sure. Okay, and that's a very good question, because you almost think, oh my gosh, I'm breathing so fast, I'm on the treadmill, what am I doing? You will breathe faster with exercise because you're increasing your metabolic rate of your body and your heart rate's going up. So when you're on the treadmill, it's pursed lip breathing. Just use pursed lip breathing. That's the best way. Would you agree?
Pursed lip breathing, diaphragmatic breathing, paced breathing. When you do it together, you're pacing it, and start out slow. I think one thing that people don't realize is they start out too quickly, and like any muscle that needs to warm up, you have muscle inside the airways, and people start too fast, and then they feel that clenching, and they stop. Another thing is that people, I think, underuse the incline. And they walk too fast on a flat surface, not realizing that it's the incline that's really going to give you the most bang for your buck. Right.
And the thing is, don't think about what you used to do. Think about what you're going to do now. So start off slow. If you get on that treadmill and you put it for 1.5 miles or 2 miles an hour, that's fine. That's amazing. That's great. And you know what? When I talk to people, I'm never interested in speed. I'm interested in endurance, because that's what's going to help you.
There's a great saying, I think it's by John Wooden, that says, don't let the things you cannot do interfere with the things that you can do. And I think that happens so often to people, whereas like their mind is their limiting factor. And I had a coach that once used to say, if you think you're going to win or you think you're going to lose, either way you're going to be right. So wherever you are today, this is your starting point. Okay,
yeah, absolutely.
You're not going to you're not going to get back to where you were 40 years ago in one day. You have to take stock. Where am I right now? And this is the starting point. And whatever, you need to make that initial ink stroke on the paper, and just get moving. Nike says just do it. I like to say just do something, almost anything, because something is always going to be better than nothing. And while I'm in the quoting mood, I'm not going to get this quote right, but it's a Martin Luther King quote, and it says, if you can't run, then walk. If you can't walk, then crawl. And another last quote, I promise, but it's one that I love. It's no matter how slow you're going, you're still lapping everybody on the couch.
Right.
So just get up and do something.
Well said.
Okay, what about having belly fat and not being able to isolate the diaphragm? And no, this question's not from me.
Well, this is the thing. You have belly fat, but maybe why don't you learn how to use it correctly? Okay, so if you have the belly fat, all right, so as I said earlier, put your hands underneath your ribs. You have a belly, but put your hands under the ribs. So what you do is sniff. That's going to you're going to figure out where what's moving. Even if it's out here, it's going to feel like moving. What you want to do is utilize the power of that extra weight, and don't just be upset with it, but utilize it. So when you breathe in, Then when you breathe out, try to squeeze the muscles in so it pushes up on the diaphragm and you get more air out. So utilize it to its best of its ability. Don't just let it just hang out and say, I can't find the diaphragm. So what you want to do is keep your posture up, sit up, put your hands on the ribs and sniff a few times. And you'll feel like some movement to the belly, and you'll feel the diaphragm's there. It's gonna happen. It just happens. I mean, there's a connection. And so if you sniff, you'll get where it is. But then what you want to do is when you breathe out, think about trying to squeeze that muscle, the muscles and the belly in to push up on the diaphragm to get more air out. The more air you get out, the better breath you get in.
Great answer. So how can someone sign up for your classes? If it's okay with you, I will post your information.
Sure.
And I also have some handouts that you gave me that you gave us permission to post. I will post those in the file section and on the wall of the Ultimate Pulmonary Wellness Facebook group. And we will make that information available to you. Do you have videos available to coach someone for the proper way to breathe? And I think the answer to that is yes.
Yes, because it's on YouTube.
Okay, and I will post all these links. Any questions you want to know about Donna and her techniques, we will post these all on the wall of the Ultimate Pulmonary Wellness Facebook group. Okay, so here's another question. This is a good question too. Steps are bad for my ankylosing spondylitis. Any good substitutes? My husband was told in December he needs a double lung. Different question. Steps are bad for my ankylosing spondylitis. Any good substitutes?
I think just, you know what, there's not a lot of substitutes for stair climbing, but I think what you want to do is make sure that you have the proper shoe on. So you're not just doing it with a slipper or something. You want a proper good support cross-trainer type of shoe, but don't do it fast. Don't just go up one step, bring the other foot up. Go up one step, bring the other step up. It's still going to make a difference in an exercise performance.
Absolutely.
Okay? It's just because you have that, it doesn't mean that the ankle spondylosis in the ankle is going to fall apart. I mean, you just have to, you might even want to wrap the ankle if you feel supported.
I think she means maybe the spine.
The spine?
Ankylosing spondylitis is the spine.
Again, if it's the ankle or the spine, it doesn't matter. The thing is, just go slow. Just take your time and go slow.
You can modify any activity.
Absolutely.
And it's like sometimes a patient will walk in the door and they'll say, you know what, I can't do any treadmill. And I say, well, you can walk. If you can walk, you can do the treadmill. Now, we don't want to beat you to where you develop an overuse injury, but your body gets good at doing what you ask it to do. And, we as Donna said, the stairs, if you want to walk upstairs, you have to walk upstairs. So, modify it, do it slower, take breaks. We don't want any musculoskeletal injuries, but I think it's worthwhile to do it modified. Next question. My husband was told in December he needs a double lung transplant due to end-stage pulmonary fibrosis. His BMI in December was 29. It is now 36. He now can't get a transplant until his BMI is less than 30. I used to be an aerobics instructor, so I know I can get him down. What do you suggest for at-home weight loss?
Okay, so I have a very strong feeling, and this is the honest. I mean, I'm not going to joke. Exercise is wellness and health. Diet
Absolutely.
Is weight loss. You have to get him off the carbs. The carbs are increasing fat. When you have too many carbs in your diet, I mean, this is a situation where he needs a double lung transplant. And yes, because we know that the modification, with complications with that high BMI, and part of the BMI is high because he's not moving. I mean, it's a catch-22 we have got here. So one, you've got to get him up and moving, but two, you've got to back off on his carbs. Now, how to lose weight really fastly? I do this with a lot of people, and I know it works. It's just that you just take all carbs away. Mm-hmm. You eat meat, fish, vegetables, and fruit, and nothing else. You do that for a week, I would guarantee you'd probably lose a couple of pounds.
Absolutely.
You have to get away from the bread. You have to get away from the rice. You have to get away from the pasta, and the cupcakes and the donuts. Nothing with white flour. And I will tell you that, one, he's probably going to feel a heck of a lot better, and two, that may make a huge difference.
You know what I wonder also is if maybe he's been on steroids. That definitely make it tough because,
Sure.
To be gaining weight like that, is pretty unusual for end-stage pulmonary fibrosis because you work so hard to breathe that typically your metabolism would be higher, and people with, you know, severe pulmonary fibrosis, the bigger issue is usually getting them to be able to keep weight on. So it might be a steroid issue as well,
Right.
in
And
which
that's
case,
fluid.
again, you know, fluid and carbs also, you know, lowering that sugar.
Yeah.
All right, only 400 more questions, Donna, don't worry. Okay, so I am a single lung transplant for 6 months. What are your best breathing recommendations? I walked and worked out an average of 6 days a week, 3.5 years. During UNOS listing, my right native lung is problematic due to emphysema, hyperinflation. My left donor lung is doing very well, and I want to optimize my new opportunity.
You know, I think, you know, your diseased lung, your emphysema lung's not going to change. It's where it is. It's going to stay that way. But just work on, you know, you can't do regional breathing. You can't breathe one lung and not the other. I mean, you've got to work both. So the thing is, it doesn't. Whatever you're going to do for your good lung is going to make the bad lung better. So what you have to do is weight training and increase the upper body strengthening. You have to do your breathing exercises, and you've got to do your cardio fitness.
Yeah, I think conditioning is key, you know, and what a lot of people don't realize, people have this idea that you can't change lung function. I definitely believe you can, but it takes, you know, progressively increasing the vigorous nature of the exercise. All right, so are lungs like other muscles when you do the breathing exercise? We're gonna have to go to speed round because there really are a lot more questions and I don't want to stay here. But are lungs like other muscles when you do breathing exercises? Do you actually improve the lungs? Are you just learning to breathe better? Do the lungs get better?
Okay, so the key is that the lungs are tissue. The lungs are not muscle.
Not muscles.
That's number one. You will breathe better as the muscles on your chest wall get stronger, so that your feeling of breathlessness will be less because you have better breathing ability. So it's the muscles that you get stronger. The lungs are tissue. You know, not to be too graphic, but, you know, all those years I did lung transplants, I mean, I saw a lot of lungs. It's just red, it's tissue, it's, you know, and there's nothing. I mean, you know, the way it works is by you using your chest wall to breathe.
Okay, towel stretch thing.
Yeah.
15 minutes total, broken up over 5 times. Is that okay?
Not 15 minutes, 15 seconds.
15 seconds.
Because if you hold your towel back there and you hold it for that long, what happens is, because you're not used to it, you're rotating your shoulder back underneath your armpit. You have this huge network of nerves called the brachial plexus, and sometimes you might feel like, oh, my fingers are going numb. So just do it 15 seconds as a stretch.
You know, it reminds me of the movie Stir Crazy with Richard Pryor and Gene Wilder, where they're like in shackles, and then they let them down. He goes, "Thank you, you cured my back problem." All right, I tend to use neck muscles, I think, when I do more walking. How do I correct this? Good question.
Chin down, chin down. Remember, this here muscle, I don't have a big one, but some of you do. It's from the sternocleidomastoid muscle. It's from the jaw, and it comes down, and it connects to the clavicle, your collarbone, and your first and second rib. So when you're walking, you're going like this. Put your chin down and walk with your chin down a little bit to relax those muscles.
Sharon, this is my girl Sharon. Do you have a videotape? My computer is not always available, and I want to share with my Breathers Club and Rehab. Do you have a videotape? DVD? What do you have?
You know, I have an old chair aerobics video, and I'm happy to give it to you, and you can put it on.
Awesome. Okay, thank you. Next, Sharon, we'll stay. Most rehabs pertain to treadmills and not upper strength training. Any advice for rehab programs?
It's a big problem. It's strength training. It's just a problem. I mean, you know, people do it because that's what they have and they have that available, but strength training is the key factor, is because you can get a good cardio fitness, but if you also have to improve the upper body.
Absolutely. What do you recommend for pulmonary hypertension? I am so inspired.
That's a hard one. Pulmonary hypertension is not something that's really curable. It's not something, I mean, it's really drug related, that you have to be on certain drugs. The only thing that we do for that is really a lung transplant.
We do exercise. I love treating pulmonary hypertension patients.
Really?
It's one of my real interests.
Really?
And we do have a webinar that I did with Evelyn Horn and Chloe Tempchin, who's like the face and voice of pulmonary hypertension. She's a young, beautiful, strong singer. So here's the thing. When we used to get pulmonary hypertension patients, we used to get an order that would say, so don't let the heart rate go above 120. But we have pulmonary hypertension patients who are 75, and we have pulmonary hypertension patients who are 40.
Right.
And they can't possibly have the same, heart rate. So again, I think the keys are conditioning, monitored conditioning,
Yeah,
because with
monitored.
pulmonary
This has to be
hypertension,
definitely
we
monitored.
really have to, monitor the pressures, okay?
Yeah.
We have to monitor the heart rate and rhythm, because you could be prone to arrhythmia. But again, many of the same principles apply. Watch the webinar. All the webinars are now at www.pulmonarywellness.com. And if you have questions, by all means, please pose them to the group. Thank you both so much. Incredibly informative. And thank you, Doc Noah, for always including us PFers. I am with you, PFers, and pulmonary hypertension and COPD. We are all together. All right, next question. I live on and you tell me when you want to call it quits.
Okay.
I live on the 3rd floor of a walk-up, 66-year-old female, severe COPD, not on oxygen. Any suggestions for the stair walking? And I think we covered this already.
I think we did, yes.
Rewind. I missed this. What is the clearance position? Okay, we didn't talk about them. There's different clearance positions for each segment and each lobe of the lung. I will try to make these available too. I'll make notes of what I need to make available. We'll put them in the file section of, again, shameless plug number 76, Ultimate Pulmonary Wellness Facebook group. And sorry, drainage position. Okay, we got it. I will put the drainage positions up.
I would say one thing. If you know you have something in your right lower lobe, say, if you have put yourself on the side, take a pillow underneath your chest, hug the pillow, and then put one pillow under your hips, so your hips are slightly higher than your shoulders. So it's kind of that. I mean, you really, to give them 18 little positions is going to be hard. I'd give them
I was going to give
basic.
them 23. You think that's bad?
Because the thing is, it's very
You're
hard.
right.
I would give them the basic, but I think that one of the most important things is that if you know that your doctor said, your lower lung fields don't look good, that means your hips have to be higher than your shoulders. So go up on 2 pillows and turn around, hug a pillow, make yourself really cozy and comfortable, and do some deep breathing in that position.
Also, tell me if you agree with this, but a basic principle is we know that we talked about gravity's effect on the lungs, and blood flow is always going to be best in the lower position, and aeration is always going to be best in the higher position. So if you're lying on your left side, then the greatest blood flow is going to be in the left lung, and the greatest aeration is going to be in the right lung, and vice versa. So like if your doctor says you have a right lower lobe something or other, then by lying on your left side, that's still going to be worlds better than upright position where it's never going to come up. Stair climbing with groceries is particularly difficult. Street walking, pursed lip. I'm not sure that I understand the question. Stair climbing with grocery. Well, carrying things are going to be tough because it's going to be extra weight that your diaphragm and your respiratory muscles have to work against. Okay, which exercise specifically strengthen your diaphragm?
The sniffle breath. The
Sniffles.
breath. In and out of the nose.
This is one of the few times somebody will recommend the sniffles. Okay. All right. So no procedure, Bactrim for 2 weeks, but did inhale 7% hypertonic saline solution for 2 weeks to reduce rales.
Okay.
I'm not sure what.
So the key is the other thing is I would tell people is if you have a nebulizer at home, when you use your inhalers, you get a portion of that medication down there, but not a lot.
Right.
But if you have a nebulizer at home and you had a lung infection, put some saline into that nebulizer and breathe in and out of the nebulizer and do it that way, because then you'll get the saline gets down in the lung, the phlegm is hydrophilic like a sponge. It absorbs everything, and then it'll loosen the phlegm and you'll get it out.
How do you relax accessory muscles that have been overtrained? They're saying overstrained, but I'll say overtrained. I have PF and can't seem to lift weights without overworking these muscles. This is a tough one. I mean, with pulmonary fibrosis or any chronic lung, you're just working so hard. You know what I would love to? I enrolled in acupuncture school because I think that acupuncture could be so great at releasing
Well, it
those
does.
muscles. And they're hard to stretch because they're in constant use.
Yeah, yeah. They're overstretched and they're overused, and you can't just go back and change that because you've been doing it for so long. But I think that if you want to do some weight training with it to maybe make the muscle stronger, just collaborate your power of your breath to breathe out as you lift.
Here's one from Jack, who I'm now learning your first name is George. Hello, Jack. Do you consider yoga to be exercise?
Yes. There's all types of yoga, so be careful. It might be, I think that some people that have some lung disease, if you started out with restorative yoga, it's excellent because it's about 5 or 6 different moves. You kind of get in and you breathe, you do a lot of breathing into it. Just be careful that you know the type of yoga you're getting into, that's all.
Don't go to Bikram first. It's 120 degrees.
Right.
All right. I've noticed that using Qigong walking, which raises arms while walking, really pulls up phlegm. Does moving arms up seem to do that in general?
Yes, because you're mobilizing all the muscles and when you're doing this and you're moving that, you're increasing lung volume. As you increase lung volume, you're going to mobilize the phlegm.
Excellent webinar. Very thorough explanations. Thank you, Donna. Sylvia, no, I'm joking. I'm happy because down below she says, hi Noah, great stuff. Because Sylvia, you know you're coming to rehab tomorrow, and we were about to get an extra strength treadmill for you. Just kidding, totally joking. All right, fantastic, thank you. I don't know, do you know Russell Winwood? So this is somebody that came here and ran the New York City Marathon with COPD. So he said, hey Donna, are you single? How important do you think weight control is in combination with regular exercise?
I think it's very important.
Okay.
I think bottom line, I mean, you've got to keep your BMI down. You've got to, keep your weight under control.
And just to follow up on that, Russell, so a lot of, pieces would have to be moving. Donna's married. I assume that would mean Leanne would be single after that if you and Donna ultimately wind up getting together. All right, this has been very helpful. Thanks so much. Want to share your insights with my NTM support group members. Do you have any videos besides the cancer one?
I have a video. It's actually a chair aerobics video that I did many, many years ago, but I'll give it to Noah and he'll get it online for you.
Thank you. I have a total gym that claims to provide all the exercises I would do in a gym, such as lower leg, upper body. If I use my O2, do you feel that would be more effective than machines in the gym?
It kind of depends how bad your lung disease is. It really, more it doesn't mean better. What maybe bring it, if you had an oximeter or could borrow an oximeter or someone could check you by doing some 10 chair squats, you could get a notion if you're going to desaturate, if your oxygen's going to go down.
I also think it's really less important people will really dissect. Is the treadmill better than this? Is this?
Oh, no.
I think it's more important that you do something. So,
do something, absolutely.
So if you're not going to go to the gym, then use the total gym at home. Absolutely. Yeah. You have to choose whatever you're going to actually do. All right, from Cynthia, the benefits of walking are vastly underestimated. Quote, my 96-year-old dad who made a 6-foot snowman last year and still walks 2 miles.
Excellent.
P.S. He made a snowman after shoveling his driveway. I will give him my address this winter. Please send him to my house. Thank you, Donna and Noah. This is life-saving and life-extending, much appreciated. Just a quote from HH, the Dalai Lama. If you think you're too small to make a difference, try sleeping with a mosquito. Good point. Good point. Thank you. Yeah, Chloe, my doctor says move. Watch pulse ox. Okay, now I think people are just heckling us. All right, 3 years ago, my pulmonary doctor on my first visit said after a 6-minute walk test that with my numbers, I had probably 5 years left. Hate when people say that. Hate it.
I have to agree with Noah 100% because no one can predict.
That left me hopeless, and as a result, where to start, anywhere. That is the worst.
It is really the worst because no one can predict, what your lung function is and how what's gonna happen. I have heard people say that, and it infuriates me because they don't know. And I have been with enough people over these 47 years to tell you that they could have the worst lung function, and they're 10 years down the road, they're doing everything.
The worst thing you could take from somebody is hope.
Yes, absolutely.
I'll tell you a story. It's short. There's only 3 questions left. But about 5 years ago, a veterinarian told me that my dog had 3 months to live because she had cancer. And for those of you that know me, don't be insulted by that. You know that I hold dogs usually in higher regard than I hold people. But it's like she lived 3 more years with green tea and exercise. But if I'll be damned if every single day for those 3 years I didn't think of those words that she has 3 months to live. When somebody tells you that you have this much time to live, unless it's really imminent, that hurts me, and that really makes me question that person's judgment.
Well, it does, because I don't think they don't have the right, no physician has the right to take your hope away.
Absolutely. I see a mosquito over there, Donna. Be careful. All right, yay for acupuncture in Cairo. Hi again, Sharon. Rena, my co-admin in 73rd, shameless plug, Ultimate Pulmonary Wellness Facebook group. Donna, you are priceless. What a pleasure to listen to. Thank you so much. Oh, and Noah, we still love you too. You're fair to average. No, I'm just kidding. I'm just joking. Thank you, Rena. Okay, here's another one. Thank you so much. You are just a treasure trove of information, and I cannot agree more. This woman is the champion, okay? I thank you so much for being here. I got an education tonight, and you are a gift to New York City and the world. Thank you so much.
Thank you.
All right,
Thank
everybody.
you, everyone.
Thank you for showing up. Thank you, American Lung Association. Thank you, Ultimate Pulmonary Wellness Facebook group. And we have one more special surprise for many of you who have asked to see him live. Monkey is here, and Monkey says hello to everybody. Thank you so much for tuning in, and trust me when I say we have big things in store for you this year, okay? We're gonna be dropping some bombs. Have a great evening. We love you. Thank you for tuning in. Have a great night.
Thank you.
Okay, super.
That was awesome.
What?
You and the